Hey, it's Dr. Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and today we're going to be talking a little bit more about Ceph X-rays. And actually, we're going to be doing a journal article review today. Woo! It's fun stuff. I know you're like, ew, journal articles, I don't like to read them. They're boring, they're hard to read. But this one was decent, it was interesting. I put the information, you can just actually, sometimes you have to go to have a subscription to PubMed in order to read these, which I certainly don't anymore. But sometimes they're available just on the internet. So this one is, so you can just look it up. I think this is, I couldn't quite tell where they were from. I think they were from maybe India or Sri Lanka or Nepal, just based on some of the things I couldn't quite tell. But the journal is called Journal of Forensic Dental Science, published in 2012. There's some interesting translations in this article, and I'm going to let you find them. When they show up, you're going to be like, oh my goodness, who did the translating on this? It's terrible. Really bad. Some of the words that were used. Even my 12-year-old daughter was like, oh my goodness, I can't believe they used that word. But anyways, I'm not going to say the word because I'll probably get kicked off YouTube if I say some of the words that are in this paper. So anyways, but what I wanted to get out of it was open up the conversation. I guess I'm a little shook up lately because I talked to a lot of general dentists. Of course, I talked to orthodontists too, just about the topic of Ceph. When do I use Ceph? When do I think you need a Ceph? And of course, going back to Cephs, this really comes down to standard of care, your own dental practice act in your own state or country. You got to go by what your dental practice act says, and I can't tell you. So sometimes I feel like we need Cephs depending on what state we're in because our dental board says we need Cephs. So you're basically taking an x-ray, and so often I feel like orthodontists are taking an x-ray and never ever looking at it. Which I believe is below the standard of care, because if you're not going to get anything out of that Ceph, why are you taking a Ceph? Because all you're doing is irradiating the patient. And I believe that is below standard of care. That's my definition. And I'll document that if I see a patient. I'll be like, don't see a reason for a Ceph. Here's why. When do I take a Ceph? I take a Ceph in growing kids, 100%. Especially if they're slightly open bite, slightly deep bite, slightly class 2, slightly class 3. I mean, if they're normal growing kids, yeah, maybe I'll get one as a baseline. But will I look at it? Probably not. Panos, of course, yes. Adults, of course, surgical patients. If they're asking for something that I don't think is possible without a surgery, or if they're asking for like a compromised outcome, they're clearly a surgical patient, they're asking for something, I'm gonna take a Ceph and I'm gonna think about it, Yeah. But for the most part, class 1 adults, no, I'm not going to take a Ceph. It doesn't make any sense. You're not going to do anything with it. Why harm the patient? Even if it's just a tiny, teeny, tiny dose, every dose adds up, right? So I don't want to be the one they come after later. I've taken beginning and final Cephs, x-rays during treatment, and patient has, I don't know, head and neck issues, cancer, and they come after. I don't know. I don't want to be part of that. So only if I need it. Obviously, if it's a huge class 2 patient who's an adult, they're not growing. But I want to see the position of the soft tissue and the teeth relative to the cranial base and the lips and all that. Okay, then yeah, I'm going to take it because I'm going to get something out of it, right? Okay. So, but what really bothers me is when doctors, often less educated doctors about what a Ceph is, they go to some class, and I'm not going to list off which classes are doing this because there's definitely some that are, because I'm so shocked when these doctors come back and talk to me, and they're like, well, the Ceph says it's 5 deviations from normal, so I definitely have to extract it, premolars. And I'm like, whoa, back it up, So, so let's talk about what is normal. Okay, this is going to be like a really philosophical conversation, and it'd be way more fun if it's 6 a.m, so I'm only having coffee. It'd be so much more fun if I had 2 glasses of wine, this conversation. But let's have a philosophical conversation about what is normal. How did they get normal, right? Well, this is a whole nother, it's actually kind of funny. You go back to the 30s and 40s, there was a guy named Broadbent, just Caucasian guy. I can't remember if he was in Minnesota or Chicago or something like that, somewhere in the the heartland. Regular people, they're probably German, they're probably Scandinavian, just regular Caucasians living in the heartland. And they just asked a bunch of doctors, for the most part, is this pleasing? Is this pleasing? And they came up with what they thought normal was. Okay, so they came up with what they thought the perfect normal face looked like. And they calculated the numbers, right? And everyone else from there, once they came to this consensus as to what normal was, based on a bunch of orthodontists who thought this something was attractive, okay? Now, all the way, we're already like 90 years from now. What was attractive back to 1930 is not what's attractive now. We've seen facial features, different things now are more quote unquote attractive. Well, that's not going to relay. So, what the patient's coming in thinking that what's attractive is not what these Ceph numbers are. Okay, so that's what I'm trying to get to you. I mean, clearly, it's helpful for me to see someone has a gigantoid open bite or a gigantoid class 3. Yeah, clearly, that's not normal. Okay, but everything else, especially the soft tissue, but not only what has really changed is in terms of the sagittal positions. Having fuller features is much more quote unquote normal and pleasing than it was 90 years ago. Full lips, bimaxillary protrusion. Patients don't want a sunken in face, but that's how they liked things 90 years ago, right? So the numbers are still on 90 years ago. So you don't want to necessarily treat to their norms. You can look at it and you can be like, I don't know about that, And you can let the patient know they're a little bit off. But 2 or 3 standard deviations off, no, that's not a problem necessarily. More than 5, maybe it should be something. But the other thing is, again, let's talk about who were their subjects. They were Caucasian people, mostly of, I believe, Scandinavian and German descent. Okay, well, we've got a lot more people in the US right now than those people. And faces are different. And what's normal for a certain ethnicity and looks good on them maybe wouldn't look good on me. Maybe it would, maybe it wouldn't, I don't know. But my concern is I've seen plenty of doctors extract teeth because someone was 4 standard deviations. Maybe they were of African descent or other different descents, and it looked bad on them after they did it. And I'm like, why are you doing this? Just because the Ceph says it's abnormal? It works for them. It works. It works for that patient. So fuller features in certain ethnicities are totally normal, totally fine, look great, it just looks fine, It may not look good on me, maybe it does. So this paper does break it down. Highlight some of the basic differences, in Japanese populations and African American populations and other populations that you can expect. And I think you just need to have that in the back of your mind when you're treating your patient. And now there's so many mixed people out there. I've got mixed kids, who's to say what is normal, Well, there are 40% Polynesian and 20% Chinese and 40% Caucasian. Well, I don't know what normal is because there is no Ceph norms for that. There's no Ceph. I can't go and say my patient is this percentage, this, and this, what's normal. It doesn't exist. So you as the doctor have to just think about this, right? So I can tell you a little story just to go back to, I did some lecturing in, where was I? Thailand. And we had doctors from all over Asia. And they kept saying, well, again, I don't want an American face. They called it an American face. I don't want an American face. It looks bad for my people. I want an Asian face. That's how my people want. But that's not necessarily true because a lot of Asians like to have things changed, certain procedures, cosmetic procedures to look a little bit more, So a lot of parents, though, I heard, a lot of doctors say that they don't want this. They have a flatter cranium, more set back features, more set back cranial base. It's normal to have everything a little more retrognathic. But then again, when you do, you also have airway issues, right? So who knows? Anyways, I think this is something that someone could really put a lot of work into. I hope that if other ortho residents are listening, think about maybe creating a new set of norms, and maybe having a computer program where you can go in and toggle what you are and you can create a norm. But again, what's a norm? What's normal? Okay, anyways, philosophical information, but the main thing is take your Ceph numbers with a grain of salt. If your patient, perhaps, if you're considering extraction, don't do the extraction just based on Ceph numbers. It's a weird thing I want to say. Look at the face. Are they lip competent? How does their face look? How are they functioning? Are they able to eat? Are they able to talk? Are they having sleep issues? All those different things come, get the feedback from the patient, the parent. If they're coming in saying she can't close her lips over teeth, her mouth is always hanging open. Okay, then, maybe we got myofunctional. There's other things you can do now. It's not always just extract. There's so much myofunctional stuff you can do that really can fix that. I really, really hate to pull teeth out unless teeth absolutely need to come out. And to be really honest, I think if you're starting early at 5, 6, eliminating habits, actually developing out the bite and the teeth to where they should be, you really shouldn't be pulling any teeth. You know, it's the adults that come in later that are refusing jaw surgery. Yeah. So, all right. Hopefully this was helpful. Thanks.